Good evening, everyone. Welcome to SUPERPoints Masterclass in Cardiology today. No matter which test you are preparing, USMLE, NEET, we have high yield material for you. And cardiology is a very, very essential subject you must master to score high in your examination. So please follow this material carefully. Watch our other videos spanning various subjects. We have high yield material in every subject that is essential for your examination. Visit our website superpoints.ai for more question banks and more material for your examination. So today let us see this question. A 79-year-old woman is admitted with worsening dyspnea, orthopnea, and bilateral leg edema. She has a history of hypertension and chronic kidney disease stage 3. Her BMI is 36 kgs per meter square. On admission, her BNP level is 2800 pg per ml. Echocardiography demonstrates a left ventricular ejection fraction of 38%. And chest radiography shows pulmonary congestion. Which of the following statements regarding the use and interpretation of BNP in this patient is most accurate? So we have like 4 choices. Choose one of the choices as your best answer, and then we will discuss this question. I will give you a few seconds. So the best answer here is choice 3. All right, choice 3. Higher BNP levels at admission are associated with increased morbidity and mortality. Let us see why is this the right answer. First of all, what is the topic? Take a couple of seconds to think about what is the topic of this question. Every question is about a topic. So think about the topic. The topic here is clinical use and interpretation of beta type natriuretic peptide BNP in heart failure. So B type natriuretic peptide BNP and its inactive metabolite NT-proBNP are cardiac neurohormones released from ventricular myocardium in response to myocardial stretch and volume overload. They play a central role in the diagnosis and prognostication of heart failure, particularly in patients presenting with acute decompensation. So we check whenever we suspect a patient having heart failure, we order BNP or NT-proBNP. And what do the levels tell us? Elevated BNP levels at the time of hospital admission are strongly associated with increased morbidity and mortality, making BNP a valuable prognostic biomarker. However, interpretation of BNP levels must consider important modifiers including obesity, which lowers BNP concentrations, and renal dysfunction, which raises BNP levels independent of cardiac status. Understanding the appropriate use and limitations of BNP testing is a high yield concept for examinations. So BNP, you need to check BNP when you suspect heart failure, right? So BNP is expressed primarily in the ventricles. Okay, that's important to know. What is this BNP? BNP is expressed primarily in the ventricles and is elevated when ventricular filling pressures are high. So whenever the pressure increases in the left ventricle or in the right ventricle, the BNP is produced. So serum BNP is a powerful prognostic marker. All right, it's a powerful prognostic marker that adds to clinical assessment in differentiating dyspnea due to heart failure from non-cardiac causes. Two markers, BNP and NT-proBNP, provide similar diagnostic and prognostic information. BNP is expressed primarily in the ventricles and is elevated when ventricular filling pressures are high. So BNP goes up whenever there is a heart failure, and this question is about hospital admission. So when the patient comes to you with a high BNP, you can say there is increased heart failure related morbidity. All right. So higher BNP or anti-BNP levels at hospital admission correlate with increased heart failure related morbidity, increased heart failure specific mortality, increased all cause mortality. So admission BNP is a powerful prognostic marker in acute decompensated heart failure. How do you remember this? So the super mnemonic here is high BNP. This is how I remember. B for bad, N for news, and P for prognostical. So high BNP, bad news, prognostical. You remember that very easily. High BNP. The patient came, you admitted him, shortness of breath, you checked BNP, there is high BNP, and immediately you can say this is bad news prognostically. And another mnemonic is in obesity we have low BNP. That means it's a falsely low. So obese patients, you need to interpret that BNP carefully. So the patient is having shortness of breath, he is obese, you checked his BNP, it looks like in the normal range. But remember, in obesity, the BNP level is falsely low. All right? It is falsely low. So he actually has high BNP even though it looks normal in the test. So it's very important that you remember that point, because obesity is raising rapidly, and when we see a low BNP in these patients, we need to interpret it based on their clinical presentation. All right. So how do I remember? I remember O for low. So O for low. In obesity, you see low BNP levels. That means they are falsely low. Right? They are falsely low. So why not other things? Why not the incorrect answers? So those of you who chose 1, 2, or 4, let us see why you are wrong. Why not daily BNP monitoring? Randomized trials show no benefit to routine daily BNP monitoring during hospitalizations. So a patient is in the hospital 5 days. Are you going to check every day? No need. All right. There is no data that is that says that is useful. Number 2, 50% reduction target before discharge. There is no recommended BNP target or percentage change required for discharge decisions. So you don't have to worry about numbers. Okay, this is not about numbers. You're treating the patient. Whenever the patient feels good to go home, he's going home. You don't have to say, I have to reduce his BNP by 50%. Number 4, obesity leads to falsely elevated BNP levels. Okay, we have already discussed that obesity is associated with lower BNP levels, decreasing sensitivity. So the take-home points from this question are: admission BNP predicts mortality. Do not trend BNP daily in hospital. No discharge BNP target. Obesity decreases BNP. On the other hand, renal failure, you see an increased BNP. Okay, in renal failure, so patient has renal failure and his BNP is high and he is normal, then don't diagnose him with heart failure. Maybe his BNP is high because his renal failure. So BNP and anti-pro BNP are equally valid but have different reference ranges. So super formula here is, super formula is like when you see a question, you see like a couple of important keywords, and in 5 seconds you know the answer. So whenever you see a patient admitted with worsening dyspnea, orthopnea, bilateral leg edema, low ejection fraction, high BNP, so what you learn from high BNP is increased heart failure related morbidity, mortality, and all cause mortality. And the super point is a high BNP or anti-pro BNP level at hospital admission predicts increased morbidity and mortality in patients with heart failure. So remember that super point. A high BNP or anti-pro BNP level at hospital admission predicts increased morbidity and mortality in patients with heart failure. So that's a very, very important and interesting question. Next, we will see this question. A 58-year-old man presents to the emergency department with 90 minutes of crushing substernal chest pain radiating to his left arm. Initial ECG shows no ST segment elevation. Serial troponin levels are pending. His vital signs at the time of admission were blood pressure 158 by 96 mmHg, heart rate 68 beats per minute, respiratory rate 22 breaths per minute, oxygen saturation 93% on room air, temperature 37.2, 99 degrees Fahrenheit. Which of the following new ECG findings in this patient indicate the need to initiate the same emergent treatment protocol used for ST elevation myocardial infarction? So we have 4 choices here. Which one do you need to initiate the same emergent treatment protocol used for ST elevation myocardial infarction? I will give you a few seconds. Please choose the best answer. So first see what is he asking about. He is asking about when do you start a patient on same emergency treatment protocol that you use for ST elevation myocardial infarction. So there are 4 choices. The best answer here is number 4, new left bundle branch block. So let us discuss this question. So what is the topic? The topic is STEMI equivalence, role of new bundle branch block in acute myocardial infarction. Let us say briefly what this entails. Acute myocardial infarction encompasses a spectrum of ischemic syndromes, all characterized by myocardial injury with elevated cardiac biomarkers. Among these, ST elevation myocardial infarction represents a medical emergency requiring immediate reperfusion therapy. So when you see ST elevation myocardial infarction, you think about immediate reperfusion therapy, right? Either you are going to use fibrinolytics to dissolve that clot, or you are going to do some angioplasty and open up those coronary arteries that constricted, right? In addition to classic ST segment elevation, certain electrocardiographic patterns, most notably a new bundle branch block, right or left, are considered STEMI equivalents. So a new bundle branch block, whether a right bundle branch block or left bundle branch block, if they are new, you consider them as ST segment equivalents, STEMI equivalents, all right, as they may mask underlying ST changes and indicate acute coronary occlusion. Recognition of these findings is critical as they mandate prompt initiation of the STEMI treatment protocol, including urgent percutaneous coronary intervention or fibrinolysis when PCI is not readily available. So this is a very high-yield concept because you are required to interpret the ECG, and also you have to make a time-sensitive clinical decision. So STEMI is diagnosed when ischemic symptoms are accompanied by either new ST segment elevation or new bundle branch block, right or left. So the patient has ischemic symptoms, and you saw ST segment elevation, so that is easy, right? But remember, if the patient does not have ST segment elevation, but he has a new bundle branch block, a right bundle branch block or left bundle branch block, you have to treat them as ST segment elevation MI. So a new left bundle branch block can obscure ST segment changes and is therefore considered a STEMI equivalent requiring immediate activation of the STEMI protocol. So management, primary PCI within 90 minutes of presentation. If PCI unavailable within 120 minutes, go for fibrinolytic therapy. So how do I remember? What is the mnemonic here? The mnemonic is new block means new STEMI. Remember like that. New block. Patient has ischemic symptoms. He has new block. So you should think of that as new STEMI. So new ST elevation, STEMI, new bundle branch block, right bundle branch, left bundle branch block, STEMI protocol immediately. So that is what you are learning from this question. Why not incorrect answers? Those of you who chose 1, 2, 3, you should listen here. Why not atrial fibrillation? You see, atrial fibrillation does not mean meet criteria for STEMI. If you see a patient with atrial fibrillation, you don't have to treat them for myocardial infarction. You are going to treat their rhythm, but you are not going to activate STEMI protocol. Why not sinus bradycardia? Sinus bradycardia can be seen in inferior myocardial infarction, but it is not itself a STEMI equivalent. You don't have to treat sinus bradycardia like ST segment elevation. Why not diffuse ST wave elevations? So you can see diffuse ECG changes in pericarditis, right? But you don't have to treat that as STEMI. So take home points from this question are new ST elevation or new bundle branch block, treat them as STEMI. New left bundle branch block, STEMI equivalent, treat immediately with PCA or fibrinolytics. The SOPER formula here is like identifying and going to the correct answer in 5 seconds. So if you see a patient comes with symptoms of acute myocardial infarction, no ST segment elevation, but there is a new left bundle branch block on ECG, you need to activate STEMI protocol immediately. All right, folks, that's an extremely important question. That's why there is a SOPER point here you need to memorize. That is, in a patient with acute ischemic chest pain, a new left bundle branch block is a STEMI equivalent and requires immediate reperfusion therapy. All right? So remember that, extremely important. If you want to give a reading on this whole thing, go to the link here I gave in AHA Journal, American Heart Association, beautiful article. You can go to that link and give a reading about it if you have time to do so. Next question. A 68-year-old man with heart failure with reduced ejection fraction is seen in clinic. His medications include enalapril, 10 milligrams daily, carvedilol, and furosemide. His blood pressure is well controlled, and the decision is made to increase the dose of enalapril to 20 milligrams daily. Which of the following laboratory tests should be obtained in 1 to 2 weeks to assess for complications of this medication adjustment? So basically this question is about you are going to increase the dose of enalapril, and what are you going to test in like 2 weeks in this patient? So there are 4 choices here. Please go ahead and choose your best answer, and we are going to discuss this. So the best answer here is number 4. This question is about ACE inhibitors, angiotensin converting enzyme inhibitors, and you should know everything about angiotensin converting enzyme inhibitors in and out, because they are most commonly prescribed medications in the entire universe. Okay, so remember everything about these medications. So why 4? All right, so let us see what is the topic. The topic is laboratory monitoring after initiation or titration of ACE inhibitors. So you started a patient on ACE inhibitors, and the laboratory monitoring, what are you going to monitor? Do you have to monitor? Yes. What are you going to monitor? That is the question. So angiotensin converting enzyme inhibitors are a foundational therapy in the management of heart failure with reduced ejection fraction and hypertension, providing significant cardiovascular and mortality benefits. However, changes in ACE inhibitor dosing can lead to important metabolic and renal effects due to suppression of angiotensin 2 and aldosterone. ACE inhibitors reduce angiotensin 2 levels, leading to decreased aldosterone. So decreased aldosterone leads to decreased sodium reabsorption and decreased potassium excretion. So what happens? There is a risk of hyperkalemia. All right. So patients have a risk of hyperkalemia. And then there is efferent arterial vasodilation. There is decreased intraglomerular pressure, and there is a rise in serum creatinine. So, therefore, after initiating or increasing the dose of an ACE inhibitor, clinicians must monitor serum potassium and serum creatinine. All right, serum potassium, serum creatinine for hyperkalemia and for worsening renal function. A rise in creatinine of up to 30% can be expected, but greater increases are associated with worse outcomes. So that's a excellent point, because many times they ask you a question, they give you a question, and they say the clinician tested creatinine after 2 weeks, starting a patient on an ACE inhibitor, and the creatinine went up to 25%. What are you going to do? And they will trap you with the first question itself is immediately stop ACE inhibitors. Okay, so don't choose that, because that is expected. All right, a rise in creatinine of up to 30% can be expected when you start ACE inhibitors. So do not stop the medication. Correct answer is continue the medication. All right, so let us say ACE inhibitors, like if you see this kidney, it is producing renin and it is converting angiotensinogen produced in the liver. It is converting that to angiotensin 1, and then that is converting to angiotensin 2. Then so angiotensin converting enzyme inhibitors act here, and angiotensin 2 causes vasoconstriction. So by blocking this, we are causing vasodilation. Okay. And the other thing is angiotensin converting enzyme inhibitors, they improve ventricular remodeling after heart failure. So after heart failure, why are we so crazy about starting patients on ACE inhibitors after heart failure diagnosis? Because they improve ventricular remodeling. All right, if you leave ventricles like that after myocardial infarction, they go berserk. All right, the remodeling needs to be controlled. That is what ACE inhibitors do. So the vasodilation happens. This vasodilation causes efferent arterial vasodilation that decreases glomerular pressure and causes a rise in serum creatinine. And also remember, aldosterone is produced and that goes down because of ACE inhibitors. And then reabsorption of sodium and water also goes down. Potassium excretion goes down, and that causes hyperkalemia. So serum creatinine is going up, serum potassium going up. So as a whole, we have decreased blood pressure because there is increased excretion of salt and water. So the take-home point here is ACE inhibitor start or dose increase, check potassium and creatinine in 1 to 2 weeks. All right. How do you remember this? ACE, K and CR. All right. Remember like that. ACE, K and CR. K for hyperkalemia and CR for rising creatinine. Why not the other answers? Why not 1 or 2 or 3? Let us say. Why not serum magnesium and sodium? Magnesium levels are not affected by ACE inhibitors, okay? And sodium monitoring is not required for ACE inhibitor titration safety. Why not serum magnesium creatine kinase? Creatine kinase is monitored in statin therapy and rhabdomyolysis because statin therapy can cause myalgia, myopathy, and even rhabdomyolysis. So in those circumstances, you check creatine kinase, but not with ACE inhibitor use. Magnesium, as I told earlier, is unaffected by ACE inhibitors. Why not serum sodium and magnesium? Neither sodium nor magnesium monitoring is routinely indicated after ACE inhibitor dose changes. You don't have to check those things, all right? You check only those two things, potassium and creatinine. So, super formula. What is super formula? Super formula is going to the core of the question by identifying the keywords. Okay, the keywords like you are titrating an ACE inhibitor and it is decreased renal potassium excretion, efferent arteriolar vasodilation. There is a risk of predictable adverse hyperkalemia and a rise in serum creatinine. So the correct answer here is mandatory check of serum potassium and creatinine in 1 to 2 weeks after dose adjustment. So super point, that is like if you forget everything, remember this important point, okay? That is after starting or increasing an ACE inhibitor, always monitor serum potassium and creatinine due to risks of hyperkalemia and reduced glomerular filtration. All right, folks. So if you want to explore more, I gave some references. Go to the references and give a reading and you will understand this concept very well. So ACE inhibitors do those things. Next question. A 67-year-old man presents with progressive exertional dyspnea and bilateral ankle swelling over past 3 months. His medical history includes hypertension, allergic rhinitis, prior episode of angioedema requiring emergent treatment. On examination, his blood pressure is 150 by 95 mmHg. He has mild jugular venous distension, bibasilar crackles, and 1+ pitting edema of the lower extremities. Echocardiography reveals a left ventricular ejection fraction of 38%. Which of the following medications should be avoided in this patient? So we have like 4 options here. Choose the best one and we are going to discuss this question. So this is also an extremely important question that you must know this concept, okay? Because this is tested almost every year. So the correct answer here is number 3, enalapril. Let us see the important things about this. First of all, what is the concept here? What is the topic? Use of ACE inhibitors in patients with a history of angioedema. Straightforward question. Patient has angioedema. Which medication should you avoid? You should avoid ACE inhibitors. Angiotensin converting enzyme inhibitors are a cornerstone of therapy for heart failure with reduced ejection fraction because of their proven mortality benefit. However, they are associated with a rare and potentially life-threatening adverse effect, angioedema, which occurs in fewer than 1% of treated patients and is more common in older adults, individuals with a history of seasonal allergies, and Black or African American patients. Current guidelines recommend that ACE inhibitors should never be initiated in patients with any prior history of angioedema, regardless of etiology, due to high risk of recurrence. Although angiotensin receptor blockers would be regarded as safe in this patient and may be considered as alternative therapy for patients who develop angioedema while taking an ACE inhibitor. Angioedema can also occur in patients taking ARBs, and extreme caution is advisable when substituting an ARB in a patient with a history of ACE inhibitor associated angioedema. So, if a patient has angioedema, do not start them on ACE inhibitor. How about ARBs? ARBs also try not to use, but if you have no choice, you need to do that under observation. All right, under observation, like an allergy specialist. You need to get ready with everything. Like if the patient is going to get angioedema, if he is going to get respiratory difficulty, pulmonary edema, you need to be ready to treat them. Do you want to take all that precautions? Yes, go ahead and start. But generally speaking, if the patient has a history of angioedema, do not start them on ACE inhibitors and ARBs. Okay, so that is very, very important. So if you look here, liver produces angiotensinogen, and that converts to angiotensin 1 through the actions of renin produced in kidney, and angiotensin 1 converts to angiotensin 2, and various angiotensin enzyme inhibitors like captopril, enalapril, lisinopril, ramipril, perindopril, quinapril, fosnapril, tadalafil, all of those prils, and that is a good way to remember them. They all end with pril. So these are ACE inhibitors. So usually angiotensin 2 causes vasoconstriction, but by blocking, you are causing vasodilation. All right. So remember this bradykinin is inactive peptides. It converts into inactive peptides. Okay. So ACE inhibitors, they block that conversion of bradykinin to inactive peptides. Because that is blocked, the bradykinin level goes up. All right. And the bradykinin is what causes angioedema. So the patients develop face swelling, lip swelling, and dysphagia. And remember, there is absence of urticaria. So this is because of bradykinin mediated disorder. All right, there is no histamine. All right, this is not a traditional allergic reaction due to high histamine. That's why antihistamines don't help these patients. So this is a bradykinin mediated disorder. So any history of angioedema is an absolute contraindication to starting ACE inhibitors. So remember that SUPERPoint for the rest of your life. Any history of angioedema is an absolute contraindication to starting ACE inhibitors. So history of angioedema, never start ACE inhibitors. So angioedema, never ACE inhibitors. All right, angioedema, history of angioedema, never ACE again. ACE inhibitors are contraindicated for life. All right, for life they are contraindicated. So why not metoprolol? Metoprolol is safe and recommended. Okay, no problem. Why not furosemide? It's appropriate for volume overload and symptom control. Why not hydralazine? Hydralazine is safe and may be used as part of vasodilator therapy in ACE inhibitor intolerant patients. So super formula here, if you see a patient with hypertension, heart failure, and if they say there's a history of angioedema, they want you to know that's an absolute contraindication to ACE inhibitor therapy. SUPERPoint, the point you must remember is this: any history of angioedema is an absolute contraindication to starting ACE inhibitors. All right, folks, that is a very, very important question, and you will get one question on ACE inhibitors in every exam. So remember these important concepts. Next, let us see this one. A 59-year-old man presents to the emergency department with crushing substernal chest pain. His past medical history is significant for erectile dysfunction, treated with tadalafil, taken as needed. The team plans to administer sublingual nitroglycerin for suspected acute coronary syndrome. What is the minimum recommended time interval that should elapse between his last dose of tadalafil and the safe administration of nitrate therapy? So these medications, phosphodiesterase 5 inhibitor medications, these tadalafil and also sildenafil, vardenafil, these medications are also most commonly prescribed medications. Whenever I prescribe these medications, I always tell people that please, if you have any chest pain and you are going to take nitroglycerin, do not take tadalafil, or keep this distance between the two medications. Do not take them concurrently. All right. So the trick here is, what is the time interval? What is the time interval? So we have like 4 choices here. Choose the right answer and we will discuss. So the correct answer here is 48 hours. And how do I remember tadalafil? This is how I remember tadalafil. Tadalafil 2 days. All right. I always remember like that. T for T. All right. So if you take tadalafil now, for next 2 days, do not take any nitroglycerin, sublingual nitroglycerin. So that's a very important point. Let us discuss this one. So the topic here is contraindications to nitrate therapy after phosphodiesterase 5 PDE5 inhibitor use. Phosphodiesterase 5 PDE5 inhibitors such as sildenafil, vardenafil and tadalafil are widely prescribed for erectile dysfunction. These agents increase cyclic guanosine monophosphate cyclic GMP levels, promoting vasodilation. Nitrates also increase cyclic GMP, and the combined effect can also lead to severe life-threatening hypertension, myocardial infarction, or death. For this reason, strict time-limited contraindications exist between the use of PDE5 inhibitors and the administration of nitrates. Because tadalafil has a prolonged half-life, 17.5 hours compared with sildenafil and vardenafil, the FDA recommends a minimum of 48 hours between the last tadalafil dose and nitrate therapy. Understanding these time restrictions is a high-yield pharmacology concept. So, you need to understand these timing restrictions. Okay. So sildenafil and vardenafil avoid nitrates for 24 hours. Tadalafil, as I told you, tadalafil 2 days, that is like avoid nitrates for 48 hours. So although a small study suggested nitrates may be safe after 24 hours with tadalafil under close monitoring, current FDA recommendations require waiting 48 hours before administering nitrates. So take home points here is nitrates plus phosphodiesterase 5 inhibitors, dangerous hypertension. Tadalafil wait 48 hours, sildenafil, vardenafil wait 24 hours. Okay. So the mnemonic here is, as I told you, TAD 2-day delay. All right, TAD tadalafil 2-day delay. Wait 48 hours before giving nitrates. And SV single day wait. All right, single day wait. So SV, remember that put like V in that W in your mental image. All right, single day wait. Sildenafil single day wait, and vardenafil single day wait. So sildenafil and vardenafil wait 24 hours. So why? So you are going to give tadalafil and the patient has nitrates, so leave 48-hour interval. And sildenafil and vardenafil leave 24-hour interval. Because cyclic GMP goes high because of increased nitric oxide, and if you give both of them, there will be decreased intracellular calcium, increased smooth muscle relaxation, and vasodilation and severe hypotension. So patient after taking, you will see even more serious reactions, as we said, hypotension, myocardial infarction, shock, death can happen. That's why nitrates with phosphodiesterase 5 inhibitors are contraindicated. The super point here is tadalafil requires a 48-hour nitrate-free interval. Sildenafil and vardenafil require 24 hours. Why not 3 hours? So that's, as I said, that's self-explanatory, right? 3 hours not enough. 10 hours, that's not enough. 24 hours, that is good for sildenafil and vardenafil, but that is not sufficient for tadalafil. So super formula here is the increased nitric oxide signaling, increased cyclic GMP, corpus cavernosum, smooth muscle relaxation, improved erection. They're metabolized by CYP3A4. Common side effects include headache, flushing, nasal congestion, hypertension. Non-arthritic, ischemic optic neuropathy can happen rarely. They're contraindicated with nitrates and used cautiously with alpha blockers. We are talking about PDE5 inhibitors. All right, folks. The super point that this point you must memorize. That is, tadalafil requires a 48-hour nitrate-free interval. Sildenafil and vardenafil require 24 hours. So remember those, just using those mnemonics. Remember that important point. Let us see next question. A 62-year-old woman presents for a routine follow-up visit 2 months after placement of a drug-eluting stent for a non-ST elevation myocardial infarction. Her past medical history is significant for type 2 diabetes mellitus for 5 years and hypertension. She was discharged on following medications: aspirin 81 mg daily, ticagrelor 90 mg twice daily, atorvastatin 40 mg daily, metformin 1000 mg twice daily, metoprolol succinate 50 mg daily, lisinopril 20 mg daily. She is asymptomatic. Her blood pressure is 128 by 76 mmHg. Her pulse is 56 beats per minute. Laboratory studies reveal LDL cholesterol 72, HDL 32, triglycerides 240, hemoglobin A1C is 8. Which of the following is most appropriate additional therapy at this time to reduce her future cardiovascular risk? So choose the best answer here. The patient has a history of drug-eluting stent for non-ST elevation myocardial infarction. So you are looking for how to reduce the risk of heart failure in this patient. So he has different medications. His blood pressure is okay, and hemoglobin A1C is not well controlled. So which of the following is most appropriate additional therapy? So choose one of those 4. The question is about how to reduce future cardiovascular risk. So choose the one best option you can. So the best answer here is number 4. Why? Let us discuss this question. What is the topic here? The topic here is secondary prevention after non-ST elevation myocardial infarction in patients with type 2 diabetes. So the patient has type 2 diabetes and he already has non-ST elevation myocardial infarction. So the goal is secondary prevention, future attacks. You want to reduce the risk of future attacks. How do you do this? Patients with type 2 diabetes mellitus and established atherosclerotic cardiovascular disease are at markedly increased risk for recurrent myocardial infarction, stroke, and cardiovascular mortality following a non-ST elevation myocardial infarction. Optimal secondary prevention includes dual antiplatelet therapy, high-intensity statin therapy, beta blockers, and ACE inhibitors when indicated. In addition to these standard therapies, contemporary guidelines recommend the use of GLP-1 receptor agonists or SGLT2 inhibitors with proven cardiovascular benefit to further reduce major adverse cardiovascular events in diabetic patients. Among these agents, GLP-1 receptor agonists, liraglutide, are preferred in patients without heart failure and with adequate blood pressure control. This integrated cardiovascular metabolic approach is a high-yield concept for board examination. So this patient has established atherosclerotic cardiovascular disease and poorly controlled type 2 diabetes. In patients with diabetes and known cardiovascular disease, therapy with the GLP-1 receptor agonist like liraglutide or an SGLT2 inhibitor with proven cardiovascular benefit is recommended to reduce major cardiovascular events. Because this patient has normal blood pressure and no heart failure, a GLP-1 agonist is preferred. All right. So the patient has no heart failure, the patient has normal blood pressure, but his diabetes is still not controlled. So we have to go for a GLP-1 agonist. All right, folks. Diabetes medications, as these oral hypoglycemic agents, they can be little bit confusing. Get a mental image of the major classes. Okay, that always helps me, and I recommend get a mental image of major classes like insulin sensitizers. We have biguanides like metformin, thiazolidine like pioglitazone and rosiglitazone. We have insulin secretagogues, sulfonylureas like chlorpropamide, talbutamide, tolazamide, glyburide, glipizide, glimepiride, glibenclamide. We have meglitinides like repaglinide and anatiglinide. Then there are incretin-based drugs like GLP-1 receptor agonists and DPP-4 inhibitors. So GLP-1 receptors, exenatide, liraglutide, lixisenatide, dolaglutide, semaglutide, albiglutide. Then there are alpha glucoside inhibitors like carbos. There are SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, ertugliflozin. There are amylin analogs like pramlintide. So we chose GLP-1 receptor agonists. Okay, GLP-1 receptor agonists, glucagon-like polypeptide 1 receptor agonists like exenatide, liraglutide, dolaglutide, lixisenatide, semaglutide. So what they do is GLP-1 receptor activation enhances insulin secretion from pancreatic beta cells. So they go through this GLP-1 receptor, adenylyl cyclase is activated, cyclic AMP goes up, protein kinase goes up, then the calcium goes in through calcium channels. They go into the nucleus, insulin synthesis increases, and insulin is released. All right. So then they suppress insulin glucagon secretion. They protect beta cells in pancreas, and they also do delayed gastric emptying. They suppress appetite. So that causes potential weight loss. So there are many good things about these medications. All right. So the take-home point here is in patients with diabetes and established cardiovascular disease, add a GLP-1 receptor agonist or SGLT2 inhibitor to reduce future cardiovascular events. So that's a very, very important point. All right. That's why you need to remember this. The mnemonic I usually use diabetic plus non-CVD, add GLP-1 or SGLT2. Just memorize that. Patient is a diabetic. He has known cardiovascular disease. Add GLP-1 or SGLT2 to control his blood sugars. So SGLT2 also is a very very important medication class. There are four things. It protects your kidney, it protects your heart, it also guards high blood pressure, it also controls blood sugars. All right, so those four things about SGLT2s are very very important. So for example, you have a patient with diabetes and he has chronic kidney disease, and his blood pressure is not controlled well, his blood sugar are not controlled well. If you get a question like that, you should go for SGLT2 inhibitors. Why? Because SGLT2 inhibitors, they protect kidney even in chronic kidney disease, and they protect heart, and these are well established studies have shown that they protect heart, and they also reduce blood pressure. So for example, if a patient has high blood pressure, this medication, even though you are using this for diabetes, it helps with their blood pressure. And finally, as the name says, because it's a diabetes medication, it also helps with diabetes. So this add GLP-1 and SGLT2 is an extremely important point. All right, you will definitely get a couple of questions on this. So please remember well. Why not add gemfibrozil? Gemfibrozil should not be combined with statins due to increased risk of myopathy and rhabdomyolysis. Why not add niacin? Large trials show no cardiovascular benefit when niacin is added to statin therapy despite raising HDL. Yes, niacin can raise HDL, but large studies have shown they don't give you any cardiovascular protection. Why not increase the dose of metoprolol? So her heart rate is already 56, okay? So because of that, increasing beta blocker dose is unnecessary. So the super formula, when you see the super formula is about identifying the keywords and the key concept and arriving at the answer in 5 seconds. So when you see a class like the increased glucose dependent insulin secretion, the decreased glucagon release, the slow gastric emptying, the increased satiety leading to reduced calorie intake, the lower hemoglobin A1C, they have low risk of hypoglycemia. When used alone, they can cause significant weight loss. They have proven reduction in major adverse cardiovascular events like MI, stroke, CV death. They are preferred in type 2 diabetes with coronary artery disease and patients without heart failure or significant hypertension. So that's a question about GLP-1 receptor agonist, just like the one we saw today. So the super point here, super point is about the most important thing. You should put this to memory. GLP-1 receptor agonists lower hemoglobin A1C, promote weight loss, and reduce major cardiovascular events, making them first-line add-on therapy for patients with type 2 diabetes and established coronary artery disease. So this patient has diabetes and established coronary artery disease. The patient is already on blood thinners and blood pressure medications, but hemoglobin A1C is still high. What are you going to do? The best answer here is GLP-1 receptor agonists. All right, folks, and next let us see this question. A 55-year-old woman with a history of episodic finger blanching and pain triggered by cold exposure presents for management of newly diagnosed hypertension. She also reports intermittent palpitations and that were previously diagnosed as supraventricular tachycardia. Her physician is considering starting a cardioselective beta blocker for blood pressure and rate control. In which of the following conditions should cardioselective beta blockers generally be avoided? So beta blockers are great drugs, but there are certain areas where they are avoided. Okay, so this is a very easy question. Choose one of the four options. So, among these four options, the correct answer is Raynaud's phenomenon. All right, because you see, the patient is saying finger blanching, pain triggered, and all this cold exposure. So, the Raynaud phenomenon is there. So, the topic is contraindications and cautions in the use of cardioselective beta blockers. Cardioselective beta blockers such as metoprolol and atenolol preferentially block beta 1 adrenergic receptors and are widely used in the management of hypertension, supraventricular tachycardia, ischemic heart disease, and hyperthyroidism. Although they are generally safer than non-selective beta blockers in patients with obstructive lung disease, they can still exert clinically significant peripheral effects. In particular, beta blockers may worsen peripheral vasoconstriction and are therefore relatively contraindicated in patients with Raynaud phenomenon, in whom they may increase the frequency and severity of vasospastic attacks. Recognizing this limitation is a high-yield concept for board examinations, emphasizing the need to tailor therapy based on comorbid conditions. So the take-home point here is Raynaud phenomenon is a relative contraindication to beta blocker therapy, even with cardioselective agents, due to risk of worsening vasospasm. All right, they cause vasospasm. That's why you should avoid them. If patient has a Raynaud phenomenon, avoid them. And how do you remember? What is the mnemonic? Block the beta in blue fingers. All right? Easy to remember, right? Block the beta in blue fingers. Blue fingers is Raynaud phenomenon. Block the beta is avoid beta blockers, even cardioselectives. All right? So the block the beta in blue fingers. That is how you remember that. Why not mild COPD? Cardioselective beta blockers are safe in mild COPD and asthma at low doses. Recent studies have shown that systemic cardioselective beta blockers are not associated with a significant increased risk of moderate or severe asthma exacerbation. Non-selective beta blockers should not be prescribed for patients with asthma, but cardioselective beta blockers, preferably in low doses, may be used when strongly indicated, and other therapeutic options are still not available. Hypertension, common and appropriate indication. Of course, you can use beta blockers in hypertension. You can use them in hyperthyroidism. They are useful for controlling adrenergic symptoms. So the super formula here is they block beta receptors, beta 1 blockade, they decrease heart rate, they decrease contractility, they decrease AV conduction, they decrease renin release, and the beta blockade leads to vasobronchoconstriction, peripheral vasoconstriction. All right, so that is undesirable. Like for example, let us say you started a patient on clonidine and you stopped the patient abruptly on clonidine, and your patient has hypertension. Are you going to give beta blockers? No. When a patient is going through clonidine withdrawal, you should not give beta blockers because of this reason. When you block beta receptors in peripheral vessels, that leads to peripheral vasoconstriction, because those beta receptors are important to vasodilate. So when you stop clonidine and the blood pressure is high, and you need that vasodilation mediated by those beta receptors. So at that point, if you give beta receptors like metoprolol, atenolol, propranolol, what happens is, like those beta receptors are inhibited, vasodilatation is inhibited, and vasoconstriction is produced. What do you have? You have severe rebound hypertension. You have hypertensive crisis. That's why whenever a patient is not taking clonidine, like for example, if he abruptly stops clonidine, you are not going to give them beta blockers. That's another important question. Usually it comes in examination. But here, Raynaud phenomenon, beta blockers should be avoided. So they are indicated in hypertension, ischemic heart disease, post-MI, heart failure, and metoprolol, succinate, carvedilol, bisoprolol, supraventricular tachycardia, atrial fibrillation, hyperthyroidism, migraine prophylaxis, essential tremor. They are avoided in Raynaud phenomenon. So they are talking about beta blockers. So whenever you see any of these keywords, they are asking you about beta blockers. So what about SUPERPoint? You must remember here is this one. Beta blockers reduce heart rate, blood pressure via beta 1 blockade, but worsen Raynaud phenomenon and bronchospasm due to residual beta 2 effects. Therefore, they should be avoided in Raynaud's, and non-selective agents avoided in asthma. All right, folks. So those are the questions I wanted to discuss today. Please visit our website www.superpoints.ai, and cardiology is extremely important. Please watch other videos I already made on cardiology, and there is cardiac pharmacology, there is cardiac physiology. The beauty of all this is you can go through everything through these clinical nuggets, whether physiology, anatomy, pharmacology, and electrocardiography, pathology, and you can go through all of those things like an integrated whole. So that is the beauty of cardiovascular system. Please visit our website, and I will see you in the next episode. Thank you.